I want to thank you for holding, and the ranking member, this hearing on the increasing crisis of opioid addiction and death. However, I'm troubled, and I hope maybe some future hearings might consider this, by the fact that we don't have any witnesses here today to speak specifically on the issues of addiction treatment and recovery, or to the policies this committee should be working on to address the needs of those struggling with an opioid addiction and to be able to help them find and receive the timely, effective help that they need to survive. As I mentioned when Secretary Burwell was here during a hearing on the President's budget earlier this month, I recently held a listening session with key addiction treatment stakeholders in New Jersey to address this growing crisis. To a person, the issue that came up as the most substantial barrier to addiction treatment was the limitation on a provider's ability to conduct medication-assisted treatment. These limitations include things like restrictions on the number of patients a physician can treat and the number of qualified providers available to treat people seeking treatment to get clean. So I was pleased that Secretary Burwell committed to taking all possible administrative steps to address these limitations. But I fear that won't be enough, and that we have to act to provide the legislative tools necessary to properly address the crisis. So with that as a preface, Mr. Cockle, would you agree that including expanded access to treatment, including medication-assisted treatment, is a critical component to any comprehensive effort to stem the tide of opioids abuse?
Senator, this is something that I think is very important, and we have been looking at it as an organization now. It's quite clear that medication-assisted treatment is an area where the evidence of effectiveness is very strong and where it's underused really across the board. So I hope we'll soon be in a position to make strong recommendations on that. We're looking at it right now.
And let me ask anyone else on the panel in a different context. As I think we all know, deaths associated with opioids have quadrupled over the last dozen years to an astounding 78 deaths a day. In addition to the issue of prescription opioids that have been a focus of this and other committees, an increasing pressing issue is the major increase in heroin use. This increased heroin issue is somewhat ironically, in my mind, the result of making access to prescription opioids become more difficult. Meanwhile, access to cheap, highly potent heroin on the streets has become, by comparison, very cheap and easy. In fact, while opioid prescribing per patient in New Jersey is among the lowest in the country, it saw a 160% increase in heroin deaths since 2010. And we suffered more than 1,200 overdose-related deaths. These statistics again point to the need to provide access to treatment as part of a comprehensive approach to combating the opioid and heroin epidemics. So I'd like to hear from you, if any of you have ideas. What steps can we take to ensure that as we make illegitimate access to prescription opioids more difficult, that we don't just push people to use drugs like heroin? Mr. Hart?
If I might, and if I could just back up to your prior question,
sure.
Which had to do what could we do to improve medication-assisted treatment. And I had earlier mentioned how we're trying to train more physicians in Oregon to use buprenorphine, especially in rural areas where it's not available. It just also strikes me as odd that mid-level providers can prescribe fentanyl, but they can't be involved in, they can't prescribe buprenorphine. So perhaps that's something to consider, because we have significant shortages in rural areas of medical providers. Regarding what can be done, well, we've been talking about this evening, but one thing to consider is how can we provide alternatives to opioids for people suffering from chronic pain, so then they don't have to turn to opioids and then inadvertently become addicted. So providing alternative therapies, providing multidisciplinary treatments, where physicians are not just paid for the 15 minutes to write a prescription, could actually create a care plan that would involve behavioral therapists, social workers, psychologists, physical therapists, occupational therapists. That's one proposal I would make.
Dr. Young?
We've been talking about the wait list, and from the child welfare perspective, we know that timely access is key. Many of the other funding sources don't necessarily have child safety and child well-being as their outcomes. So without a funding source that provides treatment for the child welfare system, it is a referral to a wait list in far too many cases.
Along with what my friends on the panel have said, I think recognizing that if at some point a proportion of this population that starts out getting the drugs through the medical system goes out and starts to, seek heroin, we have to identify further upstream. So if we can find these folks when they're visiting multiple doctors, multiple pharmacies, and at that point say, hey, stop. We need to get you into effective care. We need to manage your pain before it crosses from seeking medical treatment into a full-blown addiction. Then we will have intervened further upstream.
Mr. Chairman, thank you. I would just say that if referral to a wait list, to me, is probably a pathway to heroin if that wait list is awfully long. And so this is one of the critical elements I hope that the committee and your leadership can look at as we deal with that. Because if I'm already unfortunately addicted to opioids that I have been prescribed, and now I can get for a fraction of the cost and take care of that addiction by moving to heroin, instead of moving to a substance abuse entity that can help me permanently kick the addiction, then the reality is that if that wait list is very long, then we're on a path to a destructive course. So thank you very much for your.
Good point.